Hello there, welcome once more to this YouTube channel. Kindly subscribe to this channel. The topic is ear. The ear consists of the external, middle and internal parts. The external and middle parts are mainly concerned with the transmission of sound to the internal ear, which contains the organ for equilibrium. The equilibrium simply means, when you talk about equilibrium, it's the condition of being evenly balanced. So the external and middle parts of the ear are mainly concerned with the transmission of sound to the internal ear, and the internal ear contains the organ for equilibrium as well as organ for hearing. You have the tympanic membrane there. The tympanic membrane separates the external ear from the middle ear. Right there is an illustration of the tympanic of the ear, the external, middle and internal parts of the ear. They are all illustrated in the diagram here. In the diagram, you are going to see the tympanic membrane oval and with a green color. So the tympanic membrane, as seen in the diagram, you can appreciate that it separates the external ear from the middle ear. You also have the pharyngotympanic tube, which joins the middle ear to the nasopharynx. That tube is illustrated there with a somewhat red and peach color in the diagram. So the diagram there shows you the external ear or the outer ear, the middle ear, which it has a lemon color. The external ear there has a somewhat peach color, and then the internal ear is illustrated there. Let me start with the external ear. The external ear is composed of the shell-like auricle, what we call the pinna. The pinna is very important because it collects sound. You also have the external acoustic meatus, which is a canal as part of the external ear. The external acoustic meatus is a canal that conducts sound to the tympanic membrane. Right here is an illustration of the external ear. You can see the pinna there, and then you can see the opening that leads to the external acoustic. You can see the external acoustic meatus there. Now, what about the auricle? Let me talk about the auricle. The auricle is composed of an irregularly shaped plate of elastic cartilage that is covered by skin. The auricle has several depressions and elevations. You can see that. You can appreciate the depressions and elevations that you have in the auricle in the very first diagram that we saw. The auricle was with a somewhat peach color, or is that gold color? So you can see the depressions and elevations there. You can appreciate all that. So the auricle has it has irregularly shaped plate of elastic cartilage, and this is the elastic cartilage is covered by thin skin. The auricle has several depressions and elevations. That's why we say it's irregularly shaped. The concha is the deepest depression that you have on the auricle. The elevated margin of the auricle is called the helix. You also have non-cartilaginous lobule, what we call the ear lobe, which consists of fibrous tissue, fat and blood vessels. The earlobe is easily pierced by taking the earlobe is easily pierced, and you can have earrings inserted. You have that most females have earrings on, though these days we have some males also wearing earrings. Then some persons could pierce the ear to get blood samples. The tragus is a tongue-like projection overlapping the opening of the external acoustic meatus. The ear has three parts: external, middle and internal parts. The external part, ear, consists of the auricle and external acoustic meatus. The middle ear is an air space in which the auditory ossicles are located. Remember, we saw all the three parts of the ear in the diagram, the very first diagram, with various colors. So the middle ear is an air space where you have the three auditory ossicles located. The internal ear contains what we call the membranous labyrinth. Membranous labyrinth is divided into what we call the cochlear labyrinth and the vestibular labyrinth. Don't forget the arterial supply to the auricle. It comes from the posterior auricular and superficial temporal arteries. What about the nerves to the skin of the auricle? The nerves that are involved are the great auricular and auriculotemporal nerves. The great auricular nerves actually supplies the cranial, that's the medial surface, and the posterior part, that's the helix, antihelix, and lobule of the ear. So you have the great auricular nerve supplying the cranial, that's the medial surface, and the posterior surface of the lateral part of the ear. What about the auriculotemporal nerve? Of course, you remember the auriculotemporal nerve is a branch of the mandibular division of the trigeminal nerve. It supplies the skin of the auricle anterior to the external acoustic meatus, and you have minor contributions of embryological significance which are made to the skin of the concha. I must mention the vagus and facial nerves. The vagus and facial nerves give minor contributions to the skin of the concha and its eminence. Then a word about the lymphatic drainage of the auricle, which is as follows. You have the lateral surface of the superior half of the auricle draining to the superficial parotid lymph nodes. The cranial surface of the superior half of the auricle drains to the mastoid lymph nodes. And then, of course, the deep cervical lymph nodes also drain the superior half of the auricle. Then the remainder of the auricle, including the lobule, drains into superficial cervical lymph nodes. Now let me talk about the external acoustic meatus. The external acoustic meatus is a canal that leads inward towards through the tympanic part of the temporal bone. So the external acoustic meatus leads through the tympanic part of the, it leads in through the tympanic part of the temporal bone from the auricle to the tympanic membrane. So the external acoustic meatus goes from the auricle to the tympanic membrane, and it extends through a distance of 2 to 3 cm in adults. So the external acoustic meatus goes through a distance of 2 to 3 cm in adults. The lateral third of this slightly S-shaped canal, that's the external acoustic meatus, is cartilaginous. The lateral third is cartilaginous and lined with skin that is continuous with the auricular skin. Its medial two-thirds is bony and lined with thin skin that is continuous with the external layer of the tympanic membrane. There are ceruminous and sebaceous glands in the subcutaneous tissue of the cartilaginous part of the meatus, and this produces cerumen, that's the ear wax. You must not forget that the surface of the bulging promontory of the labyrinthine, that's the labyrinthine wall, is actually the medial wall. The labyrinthine wall is the medial wall. So the surface of the bulging promontory of the labyrinthine wall becomes grooved by the plexus of the tympanic nerve, and the tympanic nerve is actually a branch of the 9th cranial nerve, that's the glossopharyngeal nerve. The tympanic membrane is about 1 cm in diameter. It's a thin oval semi-transparent membrane. Remember, we saw it at the beginning in that diagram. It had a somewhat green color. So the tympanic membrane is at the medial end of the external acoustic meatus. The tympanic membrane forms a partition between the meatus and the tympanic cavity of the middle ear. The tympanic membrane is covered with thin skin externally and mucous membrane of the middle ear internally. When you view through an otoscope, that's an instrument used to view the ear for examination of the ear, the tympanic membrane has a concavity toward the external acoustic meatus with a shallow cone-like central depression, and the peak of this depression is what we call the umbo. UMBO, that's umbo. The central axis of the tympanic membrane goes perpendicular through the umbo like the handle of an umbrella. It runs anteriorly and inferiorly as it runs laterally. So as it's going laterally, it's also going anteriorly and inferiorly. So what you now observe is that the tympanic membrane is oriented like a mini radar or satellite dish, which is positioned to receive signals coming from the ground in front and the side of the head. So that's just what the tympanic membrane, it helps to transmit such signals. Superior to the lateral process of the malleus is one of the ossicles, auditory ossicles. Superior to the lateral process of the malleus, which is one of the small ear bones or auditory ossicles of the middle ear, you find out that the tympanic membrane is thin and is called the flaccid part. That flaccid part is actually called the pars flaccida. This part lacks the radial and circular fibers present in the remainder part of the membrane, and the rest of the membrane that has radial and circular fibers is called the tense part. The flaccid part of the tympanic membrane forms the lateral wall of the superior recess of the tympanic cavity. The tympanic membrane usually moves in response to air vibrations that pass to it through the external acoustic meatus. Movements of the tympanic membrane are transmitted by the auditory ossicles through the middle ear to the internal ear. The external surface of the tympanic membrane is supplied by the auriculotemporal nerve, which is a branch of the mandibular division of the trigeminal nerve. Of course, some innervation is also comes from a small auricular branch of the vagus nerve. Remember, the vagus nerve is the 10th cranial nerve. The internal surface of the tympanic membrane is supplied by the glossopharyngeal nerve. That's the 9th cranial nerve. Let me talk about external ear injury. You could have bleeding within the auricle. Such bleeding comes from trauma that's injury, and you now have auricular hematoma produced as a result. When you have a localized collection of blood forming between the pericardium and the auricular cartilage, you have distortion of the contours of the auricle. The usual contour you find in the auricle is lost. So as the hematoma enlarges, it compromises the blood supply to the cartilage. And if you don't treat such case, you may need to treat by aspiration of blood. If you don't treat by aspiration of blood, you will have fibrosis, that's formation of fibrous tissue developing in the overlying skin. So, and as a result, you will have a deformed auricle formed. Like in some cases, you could have a cauliflower or box ear. That is what you observe. For example, in some professional boxers or fighters that have their ear injured, and then you have such bleeding and hematoma formation, so it could deform the auricle. How is otoscopic examination done? Otoscopic examination, how do you go about it? You can examine the external acoustic meatus and the tympanic membrane by straightening the meatus. In adults, the helix is usually grasped and pulled posterior superiorly. That you pull the helix up, out, and back, up, out, and back. So when you do these movements, what happens? It reduces the curvature of the external acoustic meatus, and you now have you have an easy way to insert the otoscope. The meatus is relatively short in infants, so you have to really be careful when you're doing such examining with the otoscope, so that you don't injure the tympanic membrane. The meatus is straightened in infants by pulling the auricle inferior posteriorly. So if you want to examine use an otoscope to examine the ear in the infant, you usually pull the auricle inferior posteriorly. You go inferior and posterior, down and back. So you now have a good view for you to insert your otoscope and examine the ear. So when you examine the ear, what happens? You have a clue to why there is tenderness, that's why there is pain. It could also give you make you to appreciate why there's inflammation of the auricle or the meatus. The tympanic membrane is normally translucent and it appears gray, pearly gray. The handle of the malleus is usually visible near the center of the tympanic membrane. That's what that structure I call the umbo. Then from the inferior end of the handle of the malleus, you have a bright cone of light reflected from the otoscope illuminator. So when this is reflected, what happens? The light reflex is visible, radiating anterior-inferiorly in the healthy ear, so you can see the interior of the ear clearly. What is acute otitis externa? It's a condition in which you have acute otitis externa, you have inflammation of the external acoustic meatus, and the infection usually develops in swimmers who do not dry their meatus after swimming, and you can also have it in people that use ear drops. So you have bacterial infection as a result. There's bacterial infection of the skin lining the meatus, and such affected persons complain of itching and pain in the external ear. Pulling the auricle or applying pressure on the tragus increases such pain. Now I really need to talk about the middle ear. Right here is an illustration of the cavity of the middle ear. What we call the tympanic cavity is illustrated here. So by my extreme left here is the tympanic membrane, where you have TM is the tympanic membrane. That actually separates the external ear from the middle ear, and you have the cavity of the middle ear showing there. As seen there, the cavity of the middle ear, the tympanic cavity, is narrow, it's air-filled chamber, and it's in the petrous part of the temporal bone. The cavity of the middle ear actually has two parts. The tympanic cavity proper, that's what you have by the left there, and then you have a space directly internal to the tympanic membrane, that's the tympanic cavity proper. And then you also have what we call the epitympanic recess, and the epitympanic recess is superior to the membrane. So you have the cavity of the middle ear, that's the tympanic cavity, made up of the tympanic cavity proper right there, internal to the tympanic membrane. You can see it in the diagram. And then you now also have the epitympanic recess there, epitympanic recess, which is superior to the membrane. So both make up the cavity of the middle ear. The tympanic cavity is connected anteromedially with the nasopharynx by what we call the pharyngotympanic tube, and it's also connected posterior-superiorly with the mastoid air cells through the mastoid antrum. The tympanic cavity is lined with mucous membrane. Mucous membrane is continuous with the lining of the pharyngotympanic tube. It's also continuous with mastoid cells and the mastoid antrum. The contents of the middle ear include the auditory ossicles, that's the malleus, the incus, and the stapes. Also in the middle ear you have the stapedius and tensor tympani muscles. Nerves are also present in the middle ear. You have the caudal tympani nerve, a branch of the seventh cranial nerve, that's the facial nerve. You also have tympanic plexus of nerves, all in the cavity of the middle ear. Right here you will see an illustration of walls of the tympanic cavity. Let me talk about the walls of the tympanic cavity. The tympanic cavity, you see the walls illustrated here. Because it's a tympanic cavity, the middle ear is actually shaped like a narrow box with concave sides. So the sides are concave. There are 6 walls. You have a tegmental wall. Take a close look at the diagram. You have a tegmental wall there, what some refer to as the tegmental roof, because it's actually a roof which is formed by a thin plate of bone, the tegmen tympani, which separates the tympanic cavity from the dura mater on the floor of the middle cranial fossa. Still talking about the walls of the tympanic cavity, you also have the jugular wall, which is actually a floor formed by a layer of bone that separates the tympanic cavity from the superior bulb of the internal jugular vein. Then you also have a membranous wall. The tympanic cavity also has a membranous wall, which is a lateral wall formed by almost entirely by the peaked convexity of the tympanic membrane. Superiorly, the membranous wall, which is the lateral wall, at the superior aspect is formed by the lateral bony wall of the epitympanic recess I mentioned a while ago. Then of course the handle of the malleus is attached to the tympanic membrane here, and its head extends into the epitympanic recess. We've been looking at the walls of the tympanic cavity. I've mentioned the tegmental wall, which is actually a roof, tegmental roof. I've mentioned the jugular wall, which is actually a floor. I've mentioned the membranous wall, which is actually the lateral wall. Now you must also note the labyrinthine wall, which is the medial wall that separates the tympanic cavity from the internal ear. The labyrinthine wall also features the promontory of the labyrinthine wall, which is formed by the initial part, that's the initial part of the cochlea, that's the basal tone of the cochlea, and it's also formed by the oval and round windows. And in a dry cranium, you find that they communicate with the inner ear. So I'm talking about the labyrinthine wall, the medial wall of the tympanic cavity. So this separates the tympanic cavity from the internal ear. Very important, on the labyrinthine wall, which is the medial wall, you have the promontory of the labyrinthine wall, and this is formed by the initial part, that's the basal tone of the cochlea, and you also have the oval and round windows, and this communicates with the inner ear. Still looking at the walls of the tympanic cavity, I really need to mention the anterior carotid wall, which separates the tympanic cavity from the carotid canal. Superiorly, it has the opening of the pharyngotympanic tube and the canal for the tensor tympani. Then there is also the mastoid wall, which is the posterior wall of the tympanic cavity. There you have an opening in its superior part, the adductors, to the mastoid antrum, and it connects the tympanic cavity to the mastoid cells. So also on the mastoid wall, which is the posterior wall, you have the canal for the facial nerve, which descends between the posterior wall and the antrum. Then you also have this canal for the facial nerve medial to the adductors. So note that the mastoid antrum is a cavity in the mastoid process of the temporal bone. The antrum, like the tympanic cavity, is separated from the middle cranial fossa by a thin plate of the temporal bone, which is called the tegmen tympani. So the tegmen tympani forms the tegmental wall, that's the roof for the ear cavities. I mentioned that a while ago. The tegmen tympani is also part of the floor of the lateral part of the middle cranial fossa. The antrum is the mastoid antrum now is the common cavity into which the mastoid cells open. The antrum and mastoid cells are lined by mucous membrane, and this mucous membrane is continuous with the lining of the middle ear. Anterior-inferiorly, the antrum is related to the canal for the facial nerve. Now I must talk about otitis media. It's really troubling to have otitis media. You could have an earache and a bulging red tympanic membrane, and this indicates pus or fluid in the middle ear. This is a sign of otitis media, that's infection in the middle ear. Infection of the middle ear is often secondary to upper respiratory tract infections, because inflammation and swelling of the mucous membrane lining the tympanic cavity may cause partial or complete blockage of the pharyngotympanic tube. The tympanic membrane in such case becomes red and bulges. Then you observe an amber colored bloody fluid going through the tympanic membrane. If you don't treat otitis media, you could have impaired hearing, and this results from scarring of the auditory ossicles. With inflammation, you have chronic inflammation setting in, healing, fibrosis, and then you have scarring of the auditory ossicles, and this limits the ability for the auditory ossicles to move in response to sound, so the person might end up having hearing impairment. So middle ear infection should be properly treated, especially in children. If it is not properly treated, they might end up being deaf. What about perforation of the tympanic membrane? Perforation of the tympanic membrane could occur, and when it occurs, we say there's ruptured eardrum, because the tympanic membrane is the eardrum. It could result from otitis media, and it's one of the several causes of middle ear deafness. So when there's otitis media infection in the middle ear, it could result in perforation of the tympanic membrane, and of course that would cause deafness, middle ear deafness. Perforation of the tympanic membrane can also occur as a result of foreign bodies in the external acoustic meatus. It could also result from trauma. It could also result from excessive pressure, like when you are doing some kind of diving in some deep waters, and there's excessive pressure on the tympanic membrane. When you have minor ruptures of the tympanic membrane, such minor ruptures could heal spontaneously. But when there's a large rupture, such large rupture requires surgical repair. Because the superior half of the tympanic membrane is much more vascular than the inferior half, what happens? When you want to release pus, you make the incision to release pus from middle ear infections in the posterior inferiorly through the membrane. You do the incision posterior inferiorly through the membrane, because the superior part is more vascular. You don't want to go that way so that the patient will not bleed excessively. So you go posterior inferiorly to make an incision to drain pus in middle ear infection. Such incision is also done to avoid injury to the caudate tympanic nerve and the auditory ossicles. So when you go posterior inferior, aside from trying to avoid excessive bleeding, you're also trying to avoid injury to the caudate tympanic nerve and the auditory ossicles. What is mastoiditis? Mastoiditis is infection of the mastoid antrum and mastoid hair cells, and it results from middle ear infection that causes inflammation of the mastoid process. When infection spreads superiorly into the middle cranial fossa through the petrosquamous fissure in children, you could have osteomyelitis occurring, that's infection of the bone, and the osteomyelitis will affect the tegment tympani. So but now you have so much, thanks to the antibiotics that we have, mastoiditis is not common. When you're doing a surgery for mastoiditis, surgeons really need to be careful about the cause of the facial nerve to avoid injury. So one point you could have access is to the tympanic cavity is through the mastoid antrum. In children, only a thin plate of bone must be removed from the lateral wall of the antrum to expose the tympanic cavity. But in adults, bone must be penetrated for 15 mm or more. So when you are doing such surgery, you need to consider the age of the patient. If it's an adult, you might need to go 15 mm or more. But in children, very thin plate of bone is what you need to remove to get access to the tympanic cavity through the mastoid antrum. So now we have mastectomies that are done, but such in most cases they are done endural, that you perform the mastectomies through the posterior wall of the external acoustic meatus. Then I need to talk about the pharyngotympanic tube. The pharyngotympanic tube is illustrated right here. You can see the pharyngotympanic tube connecting the tympanic cavity to the nasopharynx, and it opens at nasopharynx, it opens posteriorly to the inferior nasal meatus. The posterolateral third of the tube is bony, and the remainder part of it is cartilaginous. The pharyngotympanic tube is lined by mucous membrane, and the mucous membrane is continuous posteriorly with that of the tympanic cavity, and anteriorly the mucous membrane is continuous anteriorly with that of the nasopharynx. What is the function of the pharyngotympanic tube? It's very important because it helps to equalize pressure in the middle ear with that that of atmospheric pressure. So when it does so, it allows free movement of the tympanic membrane. So when it allows air to enter and leave the tympanic membrane, and as it does this, it balances the pressure on both sides of the tympanic membrane. So many thanks to the pharyngotympanic tube. So because the walls, that's the crura of the cartilaginous part of the tube, are normally in a position, the tube must be actively opened. So the tube is opened by expanding the belly of the levator vali palatini as it contracts longitudinally, pushing against one wall, while the tensor vali palatini pulls on the other. So the levator veli palatini and the tensor veli palatini are very important. So the levator veli palatini contracts, and as it contracts longitudinally, it pulls against one wall of the pharyngotympanic tube. Then the tensor veli palatini pulls on the other wall. So these muscles are muscles of the soft palate, and they are very important in equalizing pressure. That's what we call popping of the eardrum. So they equalize pressure, and they are very important in when one is carrying out activities like yawning and swallowing, so they keep the pressure within the ear equalized without atmospheric pressure. There are arteries of the pharyngotympanic tube. The arteries that supply the pharyngotympanic tube come from the ascending pharyngeal artery, and the ascending pharyngeal artery is a branch of the external carotid artery. And you also have the middle meningeal artery and the artery of the pterygoid canal, which are branches of the maxillary artery. They also supply the pharyngotympanic tube. What about the veins? The veins of the pharyngotympanic tube drain into the pterygoid venous plexus. The lymphatics of the pharyngotympanic tube drain to the deep cervical lymph nodes. The nerves of the pharyngotympanic tube arise from the tympanic plexus, and the tympanic plexus is formed by fibers of the glossopharyngeal nerve, that's the ninth cranial nerve. Anteriorly, the pharyngotympanic tube also receives fibers from the pterygopalatine ganglion. Now let me talk about blockage of the pharyngotympanic tube. You must know that the pharyngotympanic tube forms a route for an infection. It forms a route for an infection to pass from the nasopharynx to the tympanic cavity. So the tube is easily blocked by swelling of its mucous membrane when there is infection. It can also be blocked by mild infections like in cold. So this blockage comes easily because the walls of its cartilaginous part are normally already in a position. So any further inflammatory exudates there or swelling will just block the pharyngotympanic tube. When the pharyngotympanic tube is occluded, what happens? Residual air in the tympanic cavity is usually absorbed into the mucosa blood vessels, and this results in lower pressure in the tympanic cavity. Retraction of the tympanic membrane and interference with its free movement is also a problem here. So you have the end result is that hearing is affected, so the individual could have hearing impairment. Now, very importantly, I need to talk about the auditory ossicles. Take a look at this diagram here. You're going to see the auditory ossicles, that's the malleus, the incus, and the stapes. They are all illustrated there. In the tympanic membrane, you have the auditory ossicles. They are all illustrated there. So they are very important as far as hearing is concerned, transmission of sound is concerned. The auditory ossicles form a mobile chain of small bones across the tympanic cavity from the tympanic membrane to the oval window. The oval window is also shown there. The oval window is called the fenestra vestibuli. You see the oval window there, illustrated there. So the auditory ossicles, like I said, they are bones that you find across the tympanic cavity from the tympanic membrane to the oval window. And the oval window is an oval opening on the labyrinthine wall of the tympanic cavity. I mentioned that a while ago. And then the oval window leads to the vestibule of the bony labyrinth. Oval window is there. It leads to the vestibule of the bony labyrinth. The ossicles, that's the malleus, the incus, and the stapes, are the first bones to be fully ossified during development and are essentially mature at birth. Very interesting about the ossicles. The bone from which they are formed is exceptionally dense, that it's hard. The ossicles are covered with a mucous membrane lining the tympanic cavity, but unlike other bones, they lack a surrounding layer of osteogenic peristeum. So the ossicles don't have peristeum like what you have in, unlike what you have in other bones. Other bones are covered by peristeum, but the ossicles lack peristeum. Now, one of the ossicles I need to talk about now is the malleus. The malleus also means hammer. It attaches to the tympanic membrane. Remember the diagram we saw a while ago. The malleus is the one that is most external, attached to the tympanic membrane. The malleus is it has a rounded superior head, and the rounded superior head lies in the epitympanic recess. Then the neck of the malleus lies against the flaccid part of the tympanic membrane. You also have the handle of the malleus embedded in the tympanic membrane. Then the tip of the malleus is actually at the umbel, and you find out that the malleus moves with the tympanic membrane. The head of the malleus articulates with the incus. So the tendon of the tensor tympani inserts into its handle, and you find this near the neck. The caudate tympani nerve crosses the medial surface of the neck of the malleus. Then you must also know that the malleus functions as a lever with the longer one of its two processes and its handle attached to the tympanic membrane. So as sound comes in, it helps in the transmission of such a sound. The incus is also another one. Incus is another one of the auditory ossicles. The incus is also called anvil. Is located between the malleus and the stapes. The incus articulates with both the malleus and the stapes. The incus has a body and it has two limbs. The body is large and it lies in the epitympanic recess. Here you find the body articulating with the head of the malleus. The long limb of the malleus, of the incus, the long limb of the incus lies parallel to the handle of the malleus. Then the interior end of the incus articulates with the stapes by way of a process we call the lenticular process. And the lenticular process is directed medially. It's a medial projection. The short limb of the incus is connected by a ligament to the posterior wall of the tympanic cavity. Okay, I cannot forget the stapes. The stapes is the smallest of the ossicles. It has a head, it has two limbs that are called the crura, and it has a base. The head is directed laterally and the head articulates with the incus. The base, which is the footplate of the stapes, fits into the oval window on the medial wall of the tympanic cavity. The oval base of the stapes is attached to the margins of the oval window, so it fits quite well. The base of the stapes is considerably smaller than the tympanic membrane. So what do you have as a result? The vibratory force of the stapes is increased approximately 10 times over that of the tympanic membrane. So you find out that the auditory ossicles increase the force, but it decrease the amplitude of the vibrations that are transmitted from the tympanic membrane. So they are very important as far as hearing is concerned. Now let me talk about muscles associated with the auditory ossicles. You have two muscles that dampen or resist movements of the auditory ossicles. One of them also dampens movement, that's vibration of the tympanic membrane. There is a muscle that is called the tensor tympani. Tensor tympani. This is a short muscle that arises from the superior surface of the cartilaginous part of the pharyngotympanic tube. It also arises from the greater wing of the sphenoid and the petrous part of the temporal bone. The muscle, that's the tensor tympani, inserts into the handle of the malleus. The tensor tympani pulls the handle medially. It tenses the tympanic membrane, and as it does so, it reduces the amplitude of its oscillations. At the end, what effect do you have? The effect is to prevent damage to the internal ear when one is exposed to large sounds. So thanks to the tensor tympani, and the tensor tympani is supplied by the mandibular nerve, which is a branch of the fifth cranial nerve, that's the trigeminal nerve. Also, talking about muscles associated with the auditory ossicles, I cannot afford to avoid mention of stapedius muscle. This is a tiny muscle inside the pyramidal eminence, that's the pyramid. It's a hollow. The pyramidal eminence is actually a hollow cone-shaped prominence on the posterior wall of the tympanic cavity. So inside it you have the stapedius muscle. The tendon of the stapedius muscle enters the tympanic cavity by emerging from a pinpoint foramen in the apex of the eminence, that's the pyramidal eminence. And when on doing that, what does it do? It inserts on the neck of the stapes. The stapedius muscle pulls the stapes posteriorly and tilts its base in the oval window. As it does so, it tightens the annular ligaments and reduces the oscillatory range. So the stapedius muscle is very important because it also prevents excess movement of the stapes. The nerve that supplies the stapedius muscle arises from the facial nerve. What happens when there is paralysis of the stapedius muscle? Paralysis of the stapedius muscle. The tympanic muscles have a protective action in that they are protected because they dampen large vibrations of the tympanic membrane that comes from very loud noises. Paralysis of the stapedius muscle, for example, you could have paralysis when there is a lesion of the facial nerve, and when there is paralysis of the stapedius muscle, the individual will suffer from excessive acuteness of hearing, what we call hyperacusis or hyperacusia, because the stapedius will not be there to dampen the large vibrations of the tympanic membrane that comes from loud noises. When there's hyperacusis or hyperacusia, you have the condition actually results from unlimited movements of the stapes, because the stapedius is paralyzed, it cannot dampen the sound. I really need to talk about the internal ear. Internal ear, right here is an illustration of the internal ear. You can see the vestibular system, the oval window, the cochlea, the round window. The internal ear, very importantly, contains the vestibulocochlear organ, which is concerned with the reception of sound and the maintenance of balance. You have the internal ear buried in the petrous part of the temporal bone. The internal ear consists of sacs and ducts of the membranous labyrinth. They are all illustrated right there. The membranous labyrinth contains endolymph, and the endolymph is the membranous labyrinth contains endolymph, and the membranous labyrinth is suspended within the perilymph filled bony labyrinth. It is suspended thanks to the delicate fibers similar to fibers of arachnoid matter that traverse the subarachnoid space. It could also be suspended by delicate fibers, so it does not float. The fluid, that's the endolymph, are very important in stimulating the end organ in the cause of balance and hearing. What do you need to know about the bony labyrinth? The bony labyrinth is a series of cavities. These cavities include the cochlea, vestibule and semicircular canals. You can see all that illustrated in the diagram. The bony labyrinth, like I said, is a series of cavities contained within the aortic capsule of the petrous part of the temporal bone. The aortic capsule is made up of bone that is denser than the remainder of the petrous temporal bone, and such bone can be isolated, carved from it using a dental drill. The aortic capsule is at times is mistakenly illustrated and called the bony labyrinth, but the bony labyrinth is actually the fluid filled space which is surrounded by the aortic capsule. So the bony labyrinth is the fluid filled space, and the aortic capsule surrounds the bony labyrinth. When you remove the surrounding bone and the aortic capsule, you see the bony labyrinth. So you have an illustration of the bony labyrinth right here. What about the cochlea? The cochlea is the shell-shaped part of the bony labyrinth. It's also illustrated in that diagram. The cochlea contains the cochlear ducts, the part of the internal ear that is concerned with hearing. So the cochlear duct is very important because it's concerned with hearing. You also have the spiral canal of the cochlea, which begins at the vestibule, and the spiral canal makes 2.5 turns around a bony core, the modulus, which is the cone-shaped core of spongy bone, about which the spiral canal of the cochlea turns. So don't forget that the spiral canal of the cochlea begins at the vestibule, and the spiral canal makes 2.5 turns around a bony core, and this bony core is called the modulus. You can see that in the diagram. The modulus is actually cone-shaped. It's cone-shaped core of spongy bone, and it's around the modulus that the spiral canal of the cochlea turns. So the spiral canal of the cochlea turns around the modulus, and the modulus is the cone-shaped core of spongy bone. The modulus contains canals for blood vessels and for distribution of the branches of the cochlear nerve. So the modulus has canals. These canals serve for blood vessels and also for distribution of the cochlear nerve. The apex of the cone-shaped modulus, like the axis of the tympanic membrane, is directed laterally, anteriorly, and inferiorly. You have a basal turn of the cochlea, which is large, and this produces the promontory of the labyrinthine wall of the tympanic cavity. So the basal turn of the cochlea is large, and it gives the promontory of the labyrinthine wall of the tympanic cavity. At the basal turn, the bony labyrinth actually communicates with the subarachnoid space, which is superior to the jugular foramen, and this communication occurs via the cochlear aqueducts. The communication is via the cochlear aqueducts. I'm talking about the cochlea. You also have the oval window. You also, in addition to the oval, you have the round window. The round window. Here you have the round window. The round window is also called in the cochlea. You don't have oval window here. What you have here is the round window. The round window. The round window is also called the fenestral cochlea, and is closed by secondary tympanic membrane. What about vestibule of the bony labyrinth? The vestibule of the bony labyrinth is a small oval chamber. It's about 5 mm long, and it contains the utricle and sacral. Vestibule of the bony labyrinth contains utricle and sacral. It also contains part of the balancing apparatus, what we call the vestibular labyrinth. The vestibule of the bony labyrinth features the oval window on its lateral wall. It features the oval window on its lateral wall. It's occupied, the vestibule of the bony labyrinth is occupied by the base of the steps. The vestibule is continuous with the bony cochlea anteriorly. Posteriorly, you have the semicircular canals and the posterior cranial fossa, which it communicates with via the aqueducts of the vestibule. The aqueduct of the vestibule extends to the posterior surface of the petrous part of the temporal bone, and here it opens posterolateral to the internal acoustic meatus. The vestibular aqueduct transmits the endolymphatic ducts. It also transmits 2 small blood vessels. Let me talk about the semicircular canals. The semicircular canals are anterior, posterior, and lateral. They communicate with the vestibule of the bony labyrinth. The semicircular canals lie posterior superior to the vestibule into which they open. So the semicircular canals open into the vestibule. The semicircular canals are set at right angles to each other, and the canals occupy 3 planes in space. Each semicircular canal forms approximately 2/3 of a circle and is approximately 1.5 mm in diameter, except at one end where there is a swelling. The swelling is called the bony ampulla. The semicircular canals have only 5 openings into the vestibule, because the anterior and posterior canals have 1 limb common to both. Lodged within the semicircular canals are the semicircular ducts. Let me talk about the membranous labyrinth. Right here is an illustration of the membranous labyrinth, consisting of a series of communicating sacs and ducts that are suspended in the bony labyrinth. The membranous labyrinth contains endolymph, which is a watery fluid similar in composition to the intracellular fluid. So when you have difference in composition from the surrounding perilymph, which is mainly extracellular fluid that fills the remaining part of the bony labyrinth. So within the membranous labyrinth, you have endolymph, which is different from the extracellular fluid that you find in the bony labyrinth. The membranous labyrinth has 2 divisions, the vestibular labyrinth and the cochlear labyrinth. So, and the 2 divisions consist of more parts than does the bony labyrinth. You have some parts, the parts of the membranous labyrinth are the vestibular labyrinth, which is made up of utricle and sacral, 2 small communicating sacs in the vestibule of the bony labyrinth. You have 3 semicircular ducts in the semicircular canal, and you have the cochlear labyrinth that contains the cochlear ducts in the cochlea. There is a spiral ligament. The spiral ligament is a spiral thickening of the periosteum lining that lines the cochlear canal. The spiral ligament secures the cochlear duct to the spiral canal of the cochlea. The remainder of the membranous labyrinth is actually suspended by delicate filaments that traverse the perilymph. Don't forget the semicircular canals that open into the auricle through the 5 openings. These semicircular canals are reflective of the way the surrounding semicircular canals open into the vestibule. The auricle communicates with the saccle through the auriculo-saccular duct, from which the endolymphatic ducts arise. The saccle is continuous with the cochlear duct through what we call the ductus reunions, which is a uniting duct. The auricle and saccle have specialized areas of sensory epithelium called maculae. The macula of the auricle is called the maculae auriculi, is in the floor of the auricle, and it's found parallel with the base of the cranium. But the macule of the saccle, called the macula sacculi, is vertically placed on the medial wall of the saccle. There are hair cells in the maculae, and these hair cells are innervated by fibers of the vestibular division of the vestibulocochlear. You have primary sensory neurons, and these primary sensory neurons are in the vestibular ganglia, and these vestibular ganglia are in the internal acoustic meatus. So endolymphatic duct traverses the vestibular aqueduct, and the endolymphatic duct emerges through the bone of the posterior cranial fossa. Here it expands into a blind pouch containing endolymphatic sac. The endolymphatic sac is located under the dura mater on the posterior surface of the petrous part of the temporal bone. You have the sac, endolymphatic sac, is actually storage reservoir for excess endolymph that is formed by blood capillaries in the membranous labyrinth. Motion sickness. What is motion sickness? You need to know that the maculae of the membranous labyrinth are primarily static organs, and they have small dense particles that are called otoliths. O-T-O-L-I-T-H-S. The otoliths are embedded among hair cells. So what happens is that under the influence of gravity, the otoliths cause bending of the hair cells. So what happens afterwards? There is stimulation of the vestibular nerve, and this provides awareness of the position of the head in space. The hairs also respond to quick tilting movements and to linear acceleration and deceleration. So that sense of awareness of the position of the head in space is the motion sickness we're talking about. So motion sickness results from discordance between the vestibular and visual stimulation. That is motion sickness. Now I need to talk about semicircular ducts. Semicircular ducts. What about the semicircular ducts? Right here is an illustration of the semicircular ducts within the semicircular canals. You can see them in the diagram there. Also illustrated is the auricle and saccle within the vestibule and the cochlear duct within the cochlea. You can see all these structures in the illustration right here. So the semicircular duct has an ampulla, a dilated portion at one end, and the ampulla contains a sensory area we call the ampullary crest. Some call it the crista ampullari. The ampullary crests are sensors for recording movement of endolymph in the ampulla, and this results from rotation of the head in the plane of the ducts. So when you have movements resulting from rotation of the head in the plane of the ducts, the crest acts as sensors to record such movements. The hair cells of the crest, like those of the maculae, stimulate primary sensory neurons that have cell bodies in the vestibular ganglia. Now, let me mention something about the cochlear duct. The cochlear duct is a spiral tube, closed at one end and triangular in cross section. It's right there in the diagram we saw a while ago. The cochlear duct is firmly suspended across the cochlear canal between the spiral ligaments on the external wall of the cochlear canal and the osteospiral lamina of the modulus. You have the cochlear duct spanning the spiral canal in a manner such that the endolymph-filled cochlear duct divides the perilymph-filled spiral canal into two channels that are continuous at the apex of the cochlea at a region we call the helicotrema. That gives a seminular communication at the apex of the cochlea. You have waves of hydraulic pressure created in the perilymph of the vestibule as a result of vibrations of the base of the stapes. And as these vibrations ascend, you have waves of hydraulic pressure created as the vibrations ascend to the apex of the cochlea by one channel. And that channel is called the scalar vestibulum. What happens to the pressure waves? The pressure waves then pass through the helicotrema and descend back to the basal tone of the cochlea. And they do so by other channels, by some other channel we call the scalar tympani. So at the scalar tympani, the pressure waves become vibrations, and this time you have the vibrations of the secondary tympanic membrane, and that energy that is initially received by the primary tympanic membrane is now finally that's dissipated into the air of the tympanic cavity. All this is very important as far as hearing is concerned. The roof of the cochlear duct is formed by the vestibular membrane. What about the floor? The floor of the cochlear duct is also formed by part of the duct as well as the basilar membrane. Then you also have the outer edge of the osteospiral lamina forming the floor as well. You have receptor of auditory stimuli there. The receptor of the auditory stimuli is the spiral organ of Corti, and it's situated on the basilar membrane. It is overlaid by gelatinous tectorial membrane. The spiral organ contains hair cells, don't forget that, and the tips of these hair cells are embedded in the tectorial membrane. The spiral organ is stimulated to respond by deformation of the cochlear ducts, and this stimulation is induced by hydraulic pressure waves in the perilymph, and these pressure waves ascend and descend in the surrounding scalar vestibuli and tympani. Whole structures are illustrated here. You can see the cochlear duct, the canal circle are all illustrated there. Where the endolymphatic duct, where you have endolymph, is also illustrated there. Let me talk about dizziness and hearing loss. When you have injuries of the peripheral auditory system, you have three main symptoms. What are the symptoms? Of course, you have hearing loss, and this hearing loss is usually conductive hearing loss. It comes as a result of when conduction of air sounds is impeded. You also have vertigo, that's dizziness, as a result of injury of the peripheral auditory system. The vertigo occurs, that's dizziness occurs when the injury involves the semicircular ducts. Then this last symptom here, which is not the least, is tinnitus, that you have this kind of ringing sounds, buzzing sounds, ringing sounds. Tinnitus is when the injury occurs when the injury is localized in the cochlear ducts. Tinnitus and hearing loss may result from lesions anywhere in the peripheral or central auditory pathways. You must Remember that there are two types of hearing loss. One, conductive hearing loss. Conductive hearing loss results from anything in the external or middle ear that interferes with movement of the oval or round windows. People with conductive hearing loss often speak with a soft voice because to them their own voices sound louder than background sounds. So a number of people you see have conductive hearing loss. You also have sensorineural hearing loss that results from defects in the cochlear nerve, brainstem, or cortical connections. Now let me say something about high tone deafness. When there is persistent exposure to excessive loud sounds, this causes degenerative changes in the spiral organ, and the result is high tone deafness. This type of hearing loss commonly occurs in workers who are exposed to loud noises and do not wear protective earmuffs, like individuals working in long hours around jet engines and very noisy areas. You also have some persons that love playing music. They play music with at very high volumes, and the speakers and amplifiers are kept close to the ear. When you do that for a long time during the day for several years, you might end up with this kind of deafness, high tone deafness. What about aortic barotrauma? What is aortic barotrauma? You can have injury caused to the ear by an imbalance in pressure between the surrounding air and the air in the middle ear. So this kind of injury is called aortic barotrauma. When there is injury caused by imbalance in pressure between the surrounding air and the air in the middle ear. This kind of injury usually occurs in flyers and divers. The internal acoustic meatus. The internal acoustic meatus is a narrow canal that runs laterally from approximately 1 cm within the petrous part of the temporal bone. You must know that the internal acoustic opening of the meatus is in the posterior part of the temporal bone, in line with the external acoustic meatus. The internal acoustic meatus is closed laterally by a thin perforated plate of bone. This plate of bone separates it from the internal ear. Through this plate of bone, you have some nerves passing. You have the facial nerve, that's the 7th cranial nerve, the vestibulocochlear nerve, that's the 8th cranial nerve, and its divisions. You also have blood vessels passing through the perforated plate of bone. The vestibulocochlear nerve divides near the lateral end of the internal acoustic meatus into two parts. You have a cochlear nerve and a vestibular nerve. Right here is an illustration of the internal acoustic meatus, also called the internal auditory meatus. It's illustrated right here. Thank you so much for listening. Don't forget to subscribe to this channel. You need to check out all the other videos on other parts of anatomy. Goodbye for now.